So that is our next topic by somebody who is, of course, going to be our next president, Dr. Thomas Cherian from Angamali. So when to refer?
Yeah. Thank you, Papa and Sudha, for this invite. Diabetic retinopathy is a disease which is primarily treated by the medical retina specialist and followed up maybe by the comprehensive ophthalmologist. But there's a certain point beyond which a medical treatment does not work, or beyond which keeping on with medical treatment might not be in the good interests of the patient. So that is when you have to refer this patient for a vitreoretinal surgery. The commonest indication for a vitreoretinal surgery in diabetic retinopathy is a vitreous hemorrhage. Not all vitreous hemorrhages need to be referred immediately, but a persistent or a recurrent vitreous hemorrhage needs an early referral. And also you have to look at whether the eye has been lasered previously or is it an unlasered retina. If it is a lasered retina, you can probably wait for a few weeks before you refer, because these vitreous hemorrhages could get absorbed over a course of time. But an unlasered retina, unless you refer it promptly and initiate a surgical treatment, the disease process underlying the hemorrhage could progress and end up in a more serious condition where even your surgical treatment might not yield good results. So an unlasered retina with a vitreous hemorrhage has to be referred as early as possible, while a lasered retina could be probably kept under observation, and if it persists, can be referred. One-eyed patients need a prompt referral. Bilateral cases end up in blindness, so needs a prompt referral. If there's an anterior segment neovascularization in the patient, that means this is not going to clear up easily with your conservative management, so it needs a referral and an initiation of surgical treatment. It's a non-clearing dense vitreous hemorrhage. And this is an eye where it is an unlasered retina. There is a hemorrhage. There are some sclerosed vessels around which needs an early referral. This is one case where I would probably look at the visual acuity. It's better to refer and leave that decision to the vitreoretinal surgeon, but before you intervene, I would probably look at the visual acuity and also keep a very close watch on the progression of the disease before I go in, because the macula is mostly normal and it might stay like this for some time and the hemorrhage could clear up or could worsen, either way. What is the role of anti-VEGF in proliferative diabetic retinopathy and vitreous hemorrhage? We go by the DRCR-NET, the protocol AB, where you have the aflibercept versus vitrectomy. In a vitrectomized eye, the anti-VEGF might clear faster. So if you plan to inject anti-VEGF later on, then probably withhold the vitrectomy for some time and see for the progression. Your anti-VEGF might work, but if it doesn't, go for a vitrectomy. If there is significant neovascularization, there is no point in waiting, because the risk of fibrosis and attractional retinal detachment are much more. So an eye with a significant neovascularization needs a vitrectomy. Stable extrafoveal tractional detachments, you can probably observe, no need to go in at the earliest. Look for progression, document the progression, and if there is progression, refer for a VR surgery. A combined tractional and rhegmatogenous detachment most of the time needs a VR surgery, so refer early. And have a case like this, I would withhold surgery in this patient. If this patient has some 618 or 624 vision, I might still withhold surgery, because that is the best possible vision you can probably have even after surgery. So this doesn't need an intervention. Of course, if the medical retina specialist who is practicing feels that it needs a referral, please go ahead and refer. Otherwise, this can probably be observed. Preretinal hemorrhage at the macula needs a referral, because these preretinal hemorrhages at the macula, that is different from the Valsalva retinopathy. A Valsalva retinopathy, you can probably do a laser and get rid of that, but a preretinal hemorrhage at the macula in a proliferative diabetic retinopathy, you have a tough preretinal membrane which doesn't give way, so that needs an early intervention. And left untreated, left with conservative management, this can go for a scarring later on, and the final outcome might not be very good. An epiretinal membrane at the macula without macular edema with significant visual loss. Without macular edema, your anti-VEGF or steroid is not going to work, so the epiretinal membrane has to come out, needs an early referral. An ERM with the DME, you can probably go for an anti-VEGF or a steroid first, look for the toning down of the macular edema, see if there is a visual improvement to your expectation. If so, leave it. Not just leave it, keep under observation, and if not, plan for a referral. If you have a vitreomacular traction with significant or progressive visual loss, it needs a referral. The vitreomacular traction has to be relieved for the vision to be restored. So this are some preretinal hemorrhages which we come across in our practice. The one on the left side, that is a large preretinal hemorrhage, obviously sparing the fovea, but this vision, the patient might have something like a 6/9 or 6/12 vision, but you have a significant vitreous hemorrhage if you see that inferiorly. So this needs a referral and early intervention. And the one on the right side, it's a well-lasered retina. There's a good panretinal photocoagulation done, but that preretinal hemorrhage is obscuring the macula. So this eye might have only something like a 6/60, and if you operate, he is going to get a 6/6 or 6/9 vision. This needs an early referral and an early intervention. This is another tricky situation where you might land up. This has a lot of neovascularization and fibrosis. It's a thick fibrous membrane covering the entire posterior pole. This patient I kept on observing because I was a bit scared that it might burn my fingers. The patient had 1/60 vision. The other eye had 6/6. So I kept pushing it off until the patient pushed me into surgery, and the patient landed up with a good visual outcome. The membrane came off as a sheet and the patient's vision improved to 6/36. In proliferative diabetic retinopathy, severe progressive PDR despite maximum laser, if the disease is progressing, if the neovascularization is progressing, you need an early intervention. And in a PDR, before taking up for a vitreoretinal surgery, either do a maximum PRP, whatever is possible, or inject, or both before you take up, because these florid PDRs are going to bleed, and they bleed badly when you take up for surgery. This is another case where we have a reasonably good laser with hemorrhage obscuring the posterior pole. This needs an early referral and early intervention. Over the past 4 decades, until the recent advent of anti-VEGF therapy, the mainstay of PDR was thermal laser to regress neovascularization, and treatment indications are still largely based on findings from the DRS. Photocoagulation reduces the risk of severe vision loss of 50% or more compared with untreated control eyes for 5 years of follow-up. If PRP has been performed previously, earlier intervention is usually recommended. PRP has not been performed previously, and the threshold for a VR referral should be low. Patients with a good PRP done earlier with vitreous hemorrhage may be observed before sending for a surgical intervention. When you are holding back your patient with a vitreous hemorrhage without a surgical intervention, you have to have a serial ultrasound to look for development of traction or a detachment. Have an ultrasound and look for the posterior pole. And patients with bilateral severe vitreous hemorrhage, you can't wait. Obviously, you have to operate at least one eye to restore the vision and make the patient ambulant. DME secondary to ERM and taut posterior hyaloid, unresponsive to intravitreal injections, needs surgery. And this is a PDR with preretinal hemorrhage. aggressive neovascularization of the disc needs an early clearance and photocoagulation with oil. TRD sparing the fovea. This is one case where I might not go in. Keep observing. This might stay on for years together like this. So you need a referral, but leave that decision to the VR surgeon. TRD involving the macula needs a referral. No other way this is going to improve. And the rate of progression of extramacular TRD to involve the macula ranges from 14 to 15% at 1 year and 21 to 23% at the end of 2 years. So role of PRP and vitrectomy, preoperative PRP may be considered with TRD if the eye has not received any lasers earlier. Though it helps stabilize the PDR, it has a risk of developing a retinal break and tractional detachment. So when you are lasering an eye with TRD, always stay away from the base of the TRD. However, keep a safe distance so that it's safe. It may also reduce the time needed to complete endolaser photocoagulation during your surgery. Thank you very much.
Thank you for that. And Dr. Thomas Cherian is going to leave any questions you want to ask. I just have one question for both of you, sir. You decided on surgery. What is the real life scenario? Do you really get vision, better vision in how many percentage of cases?
It's not. The truth is that in the recent years, the outcome of surgery with the MIVS has vastly improved. The reason for this advancements in mainly advancements in viewing systems, so we can see much better than the older. We had a very narrow field, the contact lenses. Then the surgical instrumentation has improved, and then finally the techniques have evolved a lot during this few years. If you look at the DRVS trial, they said that do not operate patients with below 6 months of when the vitreous hemorrhage is only less than 6 months. If you look at the study results, this recommendation was based on not positive outcome but negative outcome. During the DRVS trial, it was conducted in 1970s. If you operate 3 people, 1 person will go for no PL because there was no endolaser at that time. The viewing systems were not good. The surgical instrumentation was very bad. Techniques had not evolved. So out of every 3 people who operate, 1 person went for no PL. That's why they told do not rush to do surgery, wait and see, because it was not based on negative outcomes, not positive outcomes. But that has totally changed down the years. The threshold for advising surgery has become very, very low. We are happy to operate even in 6 parts vision. Unlike olden days, we used to wait for the vision to come down to close to PL or 160/260, then operate. But right now, all these advancements have helped us to operate on eyes with very good vision, and also the prognosis has been very, very different compared to the DRVS study results. So we are now happy to operate. We are more confident in giving better outcomes. That's why what we already showed. If you ask him if we operated 20 years back, he would say no. That's what I'm trying to put.
Yeah, and there are situations where you operate because you expect a good visual outcome, and there are situations you operate because you are no other way. The first group of patients, you go in early and operate. The one group of cases where you shouldn't really operate is those who are maintaining a vision for quite some time without any real progression, but they have a TRD, they are maintaining vision, especially those one-eyed patients. I would prefer not to operate.